And here, this is one of the first haboobs that has ever been taken a picture of. I took this picture at home about 15 years ago, coming to our house. And you say, well, people don't like to be outside. Well, people are chasing their garbage cans all over the place, as you can see over here. And they just moved from Chicago, so they're one of those that are really prone to getting cocci. Initial diagnosis was mentioned today already. X-rays, and this is one of the little lesions that one sees, the nodule, and that's what happens probably most frequently in Arizona. I got this nodule about 6 months after I got to Arizona 33 years ago. That's myself. That's why it's a big-hearted person. Otherwise, it goes into cavity. So understanding what you're dealing with, you have a better idea of how to then approach it serologically or by culture. This is disseminated cocci with a lymph node infection. One point about this one, this is disseminated cocci. It likes, again, the extremities. But a lot of clinicians will look at that and say, boy, this looks like a bad bacterial infection, and we'll use a swab to culture it. What you get is garbage at that point. You might even get Staph aureus growing on there, but it's not what's causing the problem. Staph aureus doesn't cause problems just like that. So cleansing that, getting a biopsy of the advancing margin would be the way to do it. I like no swabs. If you don't use swabs for anything if you can't. Get away with it. This is a 27-year-old female veterinarian, or assistant veterinarian, who had a cat brought in by a Good Samaritan, found the cat kind of lost and wandering. Cat was very ill-looking. And while they were working on the cat bit this poor assistant on the hand. The cat died 4 days later. I would be very worried assistant at this point. The vet did well for about 12 days, and then the wound began to suppurate a little bit. And she really got sick in terms of the localized infection with it actually went up progressively up towards the upper arm of that person, almost following the lymph glands. Like a sporadic presentation, but oftentimes nocardiosis will look like as well. Serologies were ordered, were negative. The serologies for cocci were ordered, were negative. Biopsy performed on hand lesion, submitted for diagnostic cultures, and guess what? We not only saw it in the calciflora, but we also grew the organism out. Importantly, from this perspective, if you look at the serologies at the bottom, 3 months afterwards, they were still negative. So serologies may be negative, especially in some of these infectious processes, and you can't rely on them all the time. How do we approach then cocci? Well, hematologic, we talked a little bit about the SED rate, and yes, not many people know how to follow the SED rates or what they really mean, but anecdotally, the chairman of our department got really bad cocci, pulmonary cocci. Everything was negative on him until much later, about a month later, he had a positive serology, submitted to Dr. Papagiannis. Serology got better, he was not treated. So serology got better to about 1 to 2, and then actually it disappeared. But his SED rate kept on being positive. Nobody followed it. He followed it himself. He was a pathologist. And he followed himself for years. He kept saying, you know, I just don't feel good. I just don't feel good. And the SED rate positive, the serology was negative in Dr. Papagiannis' lab. About 3 years later, he had cocci of his ankle. It was one of those, it had disseminated, it had lodged in the ankle. But it's almost impossible to follow those type of patients and see what's going to happen, as Dr. Ampel's data showed. As far as meningitis is concerned, I think that serologies are probably the most important component for making the diagnosis. Cultures of the spinal fluid are almost, not always, but almost invariably negative. So a serological diagnosis on CSF is very, very important. But otherwise, you can see the variations here. That it doesn't really look like it's bacterial, and that can help you make a decision which direction to go. As far as actual diagnosis, then, we have direct microscopy. I love direct microscopy because it gives you the fastest information ever possible. If you have a biopsy and you see spherules, you've got the diagnosis. You don't need anything else. You know, culture doesn't really help you except if you want susceptibilities, and we never do susceptibilities anymore, or try not to do susceptibilities because we do not see resistance in cocci. So microscopic, either spherules or mycelial forms. PCR is available at Mayo Clinic. I'm not sure how good it is at this point. I don't know. According to the study we've seen, it's as good as culture potentially, but it's often also is not negative as well, especially where it really would be helpful would be the CSF, right? It's not very good in the CSF at this time. So I think it's still an ongoing process. We have to understand where PCR is going to land. As far as urine, BAL, for the galactomannan that Dr. Ampel had mentioned, Joe Wheat's laboratory in Mira Vista, very good test. Again, I'm not quite sure exactly where it sits. It may be helpful sometimes in a disseminated case. I think BALs may be even better than sera or urine, but we're just not quite sure where to go with that. Serologic testing is still the mainstay, probably, and it's the most difficult to understand. Skin testing, I think it would be great to have back because it really can help you in making a decision. It's the first test that goes positive. Skin test is the quickest and the most sensitive. Trouble is, it's not available at this point, except in Mexico. And culture, of course. And culture is not that bad. So what do we do? As far as specimens are concerned, depends on the patient presentation. If we've got respiratory secretions, we get them. Sputum, for example, would be wonderful. Bronchoscopy, wash, or biopsy, bronchoalveolar lavage, or BALs. Normally sterile body sites also can be useful, like pleural, peritoneal, spinal fluid. Blood is not all that good. We have had positives, but it's like TB. It's so transient in the blood that it's very hard to pick it up. Like tuberculosis is transient, and you really can't do blood cultures unless you have an HIV patient, and that's a different story. So tissues, fine needle aspirates, biopsies, lung, open, brain, skin, all are very good as long as it actually goes to the site of the infectious process. For serologies, serum, spinal fluid, of course, is great. Synovial and pleural fluids are very controversial. We have experts that say they use them. Others say they're not very good at all because we get false positives. We don't know what to do with the data. So again, there's controversy in that respect. How about culture? We did a study quite a few years ago, we did a study for looking backwards at 6 years worth of data, 1,513 positive cultures. These are cultures now we got in our mycology department. We actually, right now, we grow about 350 positive cultures a year in our mycology department. These are cultures. Average days to recovery, 4.4. That's not really that bad. And as was mentioned by, we had the same as Dr. Ampel. 2 was about the fastest we could come up with. And primarily, I think, it's because of recognition issues. They're so small that you don't see them on the plates. Calcofluor, which is a fluorescent test which actually stains the chitin of the outer wall of the organism, I think is a great test. It's a very quick test that we can perform in the laboratory. We do it on all BALs, all tissues. We don't do it on sputum because the yield is much lower. But BALs and tissues we do. As you can see, it's about 22% of all culture positives we get. So it's 1/5. It gives you information much faster, within 2 to 4, 5 days faster than you would if you waited just for culture results. Types of specimens we get, I don't know if I think you can see that there. Respiratory tract for the same amount of time, get over 10,000 specimens. Non-sterile body site, 25. Look at the recovery rates on the right-hand side. You can see again, about 10% of specimens submitted were positive for cocci. Urinary tract, much less, of course. Non-sterile body sites, probably abscesses, things like that, 2.5%. Bone marrow, 2.6%. And because people really thought that's where cocci was going in the sterile site. 0.9% for CNS and other normally sterile sites. So again, respiratory tract was the best. Direct microscopy, we can do KOH mounts, which now we use calcofluor, which again is that fluorescent stain. Histopathology, to me, is really, if you got tissue, do a histopathology stain, because you can tell the reaction that you've got. You know what's going on. Even if you don't see spherules, you know what the reaction is, and it gives you an idea that it's cocci. So the pathologist can pick up on that. Several stains are good. The best one, I would think, is methenamine silver. It's the most sensitive of all the histopathologic stains. We use histopathology frequently. This is a gram stain, but don't go by this. It's one of the rare gram stains that actually stained this organism. That was because we had used KOH first. This is a spherule with endospores coming out of a sputum. This is a methenamine silver stain. You can see the endospores again. Importantly, this was a cavitary lesion. This is a better one, actually. You can see mycelial forms and spherules together. In a cavity, cocci forms mycelial forms. And I got a lot of phone calls from outside Arizona. Well, they say, you know, we've got a fungus here. It's got mycelia. It's probably not cocci, right? And I said, wrong. It is cocci. It's the same thing, because in that setting, it does produce the mycelial forms. Here's some what look like almost arthrochonea and mycelial forms in the tissue surrounding the cavity. This is a calcofluor of a spherule with endospores, just to show you what it looks like. And I'm going fast. This was a little harder. This was a specimen collected from a fine needle aspirate in lung tissue. And Cornell sent me this picture. I thought it was cocci, but boy, it sure looked weird. So you get weird things sometimes. It did turn out to be cocci, by the way. Nothing else grew. This was spinal fluid, and pathologists thought this was histoplasma. And he thought they were histoplasma yeast. When I looked at it, I didn't feel comfortable with that. Looked at the history, patient had not been out of Arizona. That was cocci-meningitis, and these were endospores. They didn't see the spherules, but they saw the endospores, and it turned out to be cocci.